Hello guys. So today I wanted to talk about Plab 2. As you know that I have taken this exam twice, and in the second attempt I was able to pass it, and I promised myself that if I pass in the second attempt I'm going to be making a video about what were the mistakes I made, and what were the differences in the first and the second attempt. So here I am. I have made a small presentation for you guys. So you can write down these points. These are some tips and tricks and that you can use in your first or second, whatever your attempt is. And I think these points are going to help you a lot. So before I go into it, I would like to tell you that in the first attempt, I scored uh, 104 and I passed 8 stations. And in the second one, I scored 113 and I passed 13 station. So my approach was basically good because I scored 11 and 12 in some of the stations in the first attempt. But the problem was the consistency, and I could not produce the same results in all the stations. So I couldn't pass more than 8 stations, and the minimum stations required for the Plab 2 are at least 10. And the usual passing score can vary from 95 to 98. So um, everyone have different weaknesses, and I'm not saying that uh, these are the tips that are going to make your success certain. But you can see if you have any of those problems that I had in my first attempt, you can work on them and hopefully pass in the second attempt. And if even if it is your first attempt, you can be aware of these factors, and I'm sure that they are going to help you a lot in your exam. So my focus is mostly on the day of the exam, because you have mostly gone through the syllabus, most of the topics, and you do not need to need you do not need any guidance on that. I'm sure. So how to be the best version of yourself during the exam, during the station, that is going to be my focus. So let's talk about it. So the first one is obviously when you are outside the cubicle, you need to utilize your time very effectively. And what do I mean by that? So they say that you are given 2 minutes, but I'm pretty sure in my second attempt, uh, because I felt like that the time was less than 2 minutes, it was passing very quickly. So I looked at the clock. There was a screen, which there was a timer, and it was 1 minute and 30 seconds. So you have 1 minute and 30 seconds to read the statement that is written outside the cubicle. Nowadays, what they are doing is that they do not give you a lot of information outside. It might be that the patient has come with some concerns, or it might be just one presenting complaint, such as hematuria or hemoptysis. So in those scenario, obviously you cannot use your cubicle time very effectively. But if there is some information given, for example, if it is hematuria, then you can give think about the diagnosis that could be, and the possible diagnosis. For example, if he's a 60-year-old male, and then you can think about the bladder carcinoma, or renal carcinoma, and you can think about the DDs while you are outside, and you can think about the question that you are going to ask once you are inside. So this is the way to use your outside time uh, effectively, and you need to see where you are. You could be in the GP surgery, you could be in the emergency, and that gives you the idea about the severity of the case. And the age of patient gives you a lot of hints about could be the disease. So if it is an elderly patient, 60 or 70, you are going to be thinking about the cancers. So this is the way to utilize the cubicle time effectively. So let's move. Okay. So the next thing I want to talk about is that obviously you are going to um, have some structures to make your history smooth and to make sure that you are not forgetting important things. But my recommendation is that do not stick to the structure very rigidly. Use it as a help, as a tool to navigate through the history, but do not solely rely on that. The problem with solely relying on the mnemonics is that you tend to ask a lot of extra things, and you seem to be very scripted, and your thoughts, they seem to be very random. So you have to ask the question in a way so the examiner knows what you are trying to rule out. If you are trying to rule out the DDs or the red flags, it should be very clear. And if you are just going through the structure, then it seems very random. For example, you're thinking about something and suddenly you ask about driving, suddenly you ask about the traveling, which is not relevant with the case. It can be sometimes relevant, but if it is not, then it seems very odd that it came out of nowhere. So I would say that use the structures, but do not be very focused on that. You should be, the most important thing should be the patient, what he is trying to tell you. And according to that, you can ask the questions rather than the structure. All right. So these are some of the structures: Lodi, Paraskov, KHTW, Meftosa. You can use all of them. So I would give you an example. So in my one of the cases, the patient had problem with alcohol, and we know that for alcohol or any drugs, we use KHTW to see if there is dependence. But once I ask a few questions about the withdrawal or the need to drink alcohol, it was very clear that she did not have dependence on the alcohol. So there was no point of me asking about if they felt guilty about drinking, or if they feel agitated if they did not have drink, or did they use the alcohol as eye opener. All of these questions are going to be irrelevant. Obviously, if one or two questions are answered, if there is dependence or not. So uh, even though I didn't do all the KHTW, and I asked a random question that what made her drink, so it was her profession that was making her drink. So I asked a lot about her profession, who she used to drink with, and all these things that seemed to be not very relevant. But I scored like 3 in the data gathering. Um, so the thing is that you need to use these mnemonics and these abbreviations very smartly, and just not be very robotic about it. You have to be very logical, and they are going to score you. Okay, so let's move to the next point, which is okay. So it is basically related to the previous point that if you are trying to ask irrelevant things, it is not going to matter, even though the information is right. In the management, you are trying to tell them that you know these things, but it is not relevant to the that specific case. It is just going to waste your time, and you are not going to be scored. uh, Lab 2 is very specific in that they do not give you any marks about irrelevant information, and that is the reason I was saying you to not rigidly stick to the structures, because in some cases, all of the meftosa, it is not going to be having any significance. Okay, past medical history is most likely important, allergy is important, family history is usually very important, but not always the diet, smoking habit or alcohol, and travel history and the profession history. They are not going to be relevant in every single case. um, but you can ask them if you feel like that you are able to utilize your time effectively. But I would say that in the second attempt, I was not very rigid. I was trying to think logically that if a patient came to me, what would I ask? Mm, let's suppose, for example, um, if you're suspecting PMS, right, or postmenopausal syndrome, so would you ask about uh, did she travel recently, or is she driving, and if she has ample support at home in terms of doing her day-to-day activities? She's 47 or 48 years old. You should not ask these questions. So just be logical. Don't be like, okay, I have to ask this question. Another problem with the following the structure is that you do not listen to the patient. You just have all these things in your mind. Okay, I'm going to ask this and this and this, and you are just not listening to the patient. And listening to the patient doesn't just mean that just say okay, okay. You have to communicate back to the patient what he has told you. So once you do that, I promise you that you are going to score very well, because they are trying to see if you are actively listening to the patient. And once you make the conversation with the patient, you are going to score good in that station. Let's move ahead. So it is very important to rule out red flags. I'm sure that you know that, and rule out 2 to 3 differential diagnoses in the data gathering. If you do that, at least 3 is going to be given in the data gathering. So yeah, that was fairly easy to understand. So let's move to the next one. Again, the same thing. Do not go to the irrelevant questions. Be precise, because you have only 8 minutes. You cannot be spending a lot of time on irrelevant things. Um, yeah, that's it. And again, if you engage in the conversation with the patient, and they are going to open up and they are going to um, talk to you, yeah, and once the simulator or an actor is talking to you, then you can be sure that you are going to be scoring good in that station, because you have made them comfortable. And that is the whole point of the consultation, that patient is comfortable to talk to you, to open up to you and share the problem he's having. Again, I told you that in the cubicle you can make up your mind what you're going to be asking, but it doesn't mean that you go suddenly inside and just asking, okay, where's the pain? Is it radiating to somewhere else? And does it come and go? Don't be like that. Listen to the patient. Start with the open-ended questions. So, can you please tell me what happened? Okay, can you tell me more about it? These sort of questions allow the simulator to say a lot of things, and they will tell you most of the things that you need to ask. And one more important thing is that if they have told you something, do not ask again, because it is in your structure. Actively listen. You have to be very present in the room. You have to be alert. You have to be not focused on the structure, the patient. If you ask the question they have already told you, then they might point it out, or doctor already told you that this the answer of this, and this is not going to look very good to the examiner. So it is very important that you do not do that. Again, these things you cannot control it, but what if I told you that most of the people who fail the exam, the only the main reason they fail it is because they got nervous, and that is the only problem. Obviously, if you are taking $1,000 £1,000 exam, um, you are not going to be unprepared for that. You have uh, gone through all the notes, you have practiced a lot. But the one thing that is not in our control is to have the control of our nerves and not be nervous during the exam. And that is the problem most of the people face. So my recommendation is that people usually do get nervous if they get one of the stations wrong, and it is very difficult for them to uh, have a hold of their nerves, and they mess up the upcoming stations, which is very ridiculous, because you never know if your station went well or not. Because sometimes you are thinking you have failed this station, and when the results come, and you say, oh my god, I thought I failed it, but I scored very high in that. The reason is that the examiner is not looking for you to diagnose always, and they are looking if you are trying to rule out the red flags and you are a safe doctor or not, you are safety netting or not. So never assume in your station that it went bad or it went good. You never know. So if you think it is bad, do not too much stress about it. You could have scored good in that, and just focus on the next one, because if you think that it didn't go well, it will mess up your whole performance in the second and the third station. So that is my advice about not getting nervous. Okay, so the next point is you need to know the exact management. So if you talk to the people who have given the exam and ask them where they lagged, so they are going to tell you that they got the least marks in the management. So you need to know very, very precise management. You know, do not need to know 4 or 5 points, but the most definitive management, you need to know that. And if you tell the patient about it, they are going to give you at least two, which are needed to pass the station. If you tell them extra symptomatic management, the investigations, the referral, the safety netting, the follow-up, then obviously you are going to score 3 to 4. I would recommend that you go through the GK's notes, because they are very up to date, and there is also an option for the subscription of the apps, in which the notes are very precise. You do not need to go through the whole GK's notes. So I would recommend buying subscription of the GK's notes. Okay, so one more thing, I knew about it, but still I feel the Simon and the prescription both. I knew that these are going to save you, but I tell you again that the Simon prescription, if you pass them, it is very unlikely that you're going to fail the Type 2 exam. So, and we know for sure that Simon and prescription are going to come. Simon, it comes about 90% of the times, and prescription is there all the time. So practice prescription daily, and the Simon as well. You need to have them on the fingertips. Procedures, they sometimes come and sometimes do not come, but if you do them good, then it also makes sure that you are going to pass the exam. So Simon and prescription, they are the buffer, and you need to utilize them. Even everything goes bad, if you have Simon and prescription passed, then most likely you are going to pass the exam. So that's it. I do not think I have anything else in my mind. Do prescription and Simon daily, and practice with a pillow if you do not have any access to the mannequin. You just need to, I would say that you memorize the statements that you need to say once you enter the room, and whatever you have to say, because it is your second language, so we have a little difficulty in speaking. So if we focus too much on what we are saying, then obviously we are not going to be able to do what we need to do, which is to grab the equipments from the crash trolley and take the history as well. So it is kind of a multitasking. So I would suggest that you remember the phrases that you need to say to the patient, so you do not need to think about them. And I can make some videos if you like. You can comment down below. It is very similar to the ALS, and in the ALS, uh, the people from the resuscitation council, they taught us how to do the E to E approach. So I know that approach as well, and I think that is the approach that is expected from Plab 2. So if you say, I can make videos about that. And best of luck for your Plab 2. Thank you.